Leading off our second session is Junho Kim. Junho is a fellow in general medicine and primary care at Ariadne Labs, Harvard Medical School, and the Brigham and Women's Hospital. The title of his presentation is Global Learnings in Adapting Health Systems for Pandemic Response. Junho, take it away.
Thank you, Susan, and to the Ariadne community for this opportunity to share about our global learnings work, of which I'm representing a large team. Next slide, please. So this week in Foreign Affairs, in an article titled Exceptionalism is Killing Americans, Jeremy Konendijk wrote that the notion that the United States is unique among nations and that the American way is invariably the best has blinded the country's leaders and many of its citizens to potentially life-saving lessons from other countries. And in the Financial Times this week, we can see that the United States has essentially adopted a strategy that has led us to plateau in the number of daily cases. In many other countries, despite having large outbreaks, many have actually bent the curve. So if we're committed to saving lives, we need to get beyond our complacency and exceptionalism and learn from these other countries and adapt their lessons here. Next slide. So as such, in March, we set out to study both positive and negative outlier countries like South Korea, Japan, and Italy, and distill infection control and prevention principles and strategies that could be compared and adapted in other countries. We reached out into the Boston public health and medical community and partnered with a dozen volunteers across 3 teams. The teams interviewed over 40 frontline providers and health officials across the 3 countries and procured various protocols and playbooks at the national and hospital level. We produced 2 evidence briefs, one on Korea that was released last month on the Ariadne website, and another on Japan that we'll release this week, along with an Italian brief that's in progress. We've also written smaller, focused case studies in collaboration with colleagues, such as a case study on the outbreak in Daegu, which was published in New England Journal Catalyst last week. In the Daegu study, we highlight key ways that local health systems can respond to future waves of the pandemic to bend the curve, minimize nosocomial infections, and maintain care for non-COVID-19 patients. Meanwhile, we were fortunate to work with a group of over 130 volunteers from around the world on the COVID Translate project, which used crowdsourcing to translate nearly 20 protocols and guidelines from South Korea into up to 6 languages. Thanks to our Ariadne network, we've been able to share this with a variety of stakeholders, from the Gates Foundation to our local Massachusetts COVID-19 State Command Center to the Italian government. Next slide. So the power of this project has been really in the collaboration and crowdsourcing of perspectives, skills, and social networks. We're in a unique time when we can rapidly mobilize people around the world and collaborate across platforms from Zoom to Slack to Google Docs. This effort truly would not have been possible without an incredible team of motivated and highly resourceful individuals. Next slide. So to take this to the next level this summer, our Ariadne primary healthcare team will be facilitating convenings with multiple countries through the Joint Learning Network and the Gates Foundation. This will allow countries to compare and contrast their strategies for COVID response. We also hope to engage in substantive discussions, including policymakers in Japan, to make sure these lessons lead to continuous improvement in preparation for future waves of COVID-19 and future pandemics. We're very big in America on breakthrough innovations, but we at Ariadne emphasize the value of follow-through innovations. If we're able to understand the strategies that other governments and public health agencies have put together, the keys to success are all there. We just have to be willing to think globally, even while we act locally. Thank you.
Thank you, Junho. I have really a 2-part question for you. What's the top lesson from these countries that you would want to see implemented in the United States? And then secondly, what's the biggest barrier in the United States, beyond exceptionalism as a way of thinking, to get these lessons implemented?
Thank you, Susan. I think the first kind of basic but really big picture lesson is that the virus can be contained through public health fundamentals. We don't have to be at this plateau. It's not an invisible enemy. We can make it visible through better coordination, testing, and tracing. And I think these other countries have shown that we can weaken it through physical distancing, hand hygiene, and masks. I know you said kind of top lesson, but one other lesson for me has been that the Departments of Public Health or command centers really need the authority and protocols to coordinate across hospitals and clinics. When we first asked South Korean health officials and ID doctors about how they protected their healthcare workers, the first answer wasn't about PPE, which is unquestionably critical. The first response was really, we triage patients by their risk level into designated COVID-19 hospitals and isolation units. And so they were able to keep suspected cases separate from non-COVID patients and providers. So we can't continue our strategy of triaging patients when they show up in the emergency room. We have to look and coordinate more broadly. And just lastly, in terms of just a barrier, I think other than exceptionalism, I do think our fragmented healthcare and payment system are significant barriers of having a coordinated strategy. When health systems, screening centers, and laboratories are all operating independently and in separate contracts with multiple payers, it's really hard to have a unified response.
Great. Thanks so much, Junho.